As mentioned, I'm a clinical cardiologist and researcher. I'm interested in the connection between exercise and cardiovascular risk. And a lot of the stuff that I'm motivated to research and learn more about is inspired by the challenges I face in clinic. As mentioned, I treat athletic and highly active patients. And so it's sort of a niche within cardiology. And I have been asked today to talk about exercise dose. You know, this audience doesn't require convincing. I had a great intro from Eric at the beginning that exercise is medicine. But just like any medication we prescribe, the question is, what is the dose response between that medication and the long-term health outcomes? And this is just one graph you could show of many showing that relationship. The association between physical activity and longevity, the inverse of mortality, is shown on that graph. You could draw a similar dose response curve for cardiovascular disease and then for some cancers as well. These are observational data, and what they tell us is that increasing levels of physical activity are associated with improved longevity here, with the biggest impact being from getting off the couch, improving from being sedentary. Further improvements as you get towards the sort of guideline recommended doses of physical activity. That's the oft-repeated 150 minutes of brisk walking per week. You get double credit for anything more intense, so that's 75 minutes per week for those out there running and cycling. And then you get some further health gains if you get up towards 2, 3, 4, 5 times that baseline amount of physical activity. A lot has been made about the right-hand side of this dose response curve, and this is not the only study that's shown this. There's others that similarly have this sort of reverse J shape to the curve, where more increasing doses of physical activity, here those doing 10 times the recommended dose amount, is associated with a slight uptick in mortality from that sort of optimal baseline. Now, this is a study, the one shown here, of over 600,000 individuals. You're not really going to get bigger cohorts than that. And even this group was unable to collect enough individuals doing these uber amounts of exercise to narrow what you see the confidence intervals here. So no study like this is able to say that there is a sort of too much, too little, just right dose response curve. But we see this reverse shape curve dating back to studies from long, long ago. This particular one I'm showing is self-report, and that kind of work, which has been going on for decades, has been more recently affirmed by wearables cohorts that wore accelerometers 10 or 15 years ago, and we've been able to look at outcomes over the ensuing decade and a half. Because wearables capture all of our physical activity, you see even more benefit, and that little inflection up in risk comes at a little bit lower dose because, of course, a wearable is able to capture a flight of stairs, whereas self-report is harder to capture those smaller amounts of physical activity. I absolutely love that we started our day talking about what is the source of the data that we are discussing. Because as I think I've been cautious, I should not at any point so far have said the word cause. Because what we have with relationships between physical activity and longevity and long-term health outcomes, the things at the bottom of this table, are only observational data. So we have to be careful to say X associates with Y, but not that physical activity causes longevity, causes reductions in cardiovascular disease. We have to be very careful there. But that is the bedrock of data that we have, because it's not practical to tell a human or have a human be randomized to one level of physical activity versus another for long enough to look at these long-term outcomes. Eric set things up perfectly because we do have a wealth of shorter, sometimes randomized to two different types of exercise data, studies that are looking at the impact of a specific exercise intervention on specific outcomes. And these are things like the top of this table here. So you could say type of exercise X versus type of exercise Z results in improvement in a given short-term outcome, right? But we have to be very careful not to overinterpret those studies and extrapolate to say that X form of exercise versus Y form of exercise leads to longevity, because these short-term things that are at the top of the table here certainly improve our lifespan and our health span, but we don't have the data to say that to take the jump to say how exercise impacts these then leads to longevity. And it's important we connect those dots. Eric alluded to this fact, but this is what drives some of the fads in exercise that we see. You have studies that might say, for example, high intensity interval training, this was very in vogue 5 years ago, is the way to live your longest because it improves your visceral fat, just for example. And then you have tides turning. We're all meant to be doing zone 2 right here. as a runner, I like that much better. So let's not overinterpret those data. And really the bedrock of what we know about physical activity and longevity is the observational data. Now, if you break apart the dose, and this is the minimal recommended dose by our guidelines, 150 minutes per week of moderate intensity exercise on an absolute scale, so that's brisk walking. The question is, from the observational data, can we do a little bit better and break apart, how frequently you do that how long each your bout is and how intense it is, does that impact long-term health? And the short answer, disappointingly, is no. So you can accrue your bouts of exercise 5 minutes at a time. You could do it all on the weekend. You could do it at high intensities. You could do it at moderate intensities. And when we look at longevity and long-term outcomes, it seems not to matter. This, to me, is good news and bad news. Good news from a public health perspective is that to our patients, what really matters is moving your body. The message can be very simple. The bad news is, like most of the people coming to this conference today would appreciate more nuance, right? And I think probably there is more nuance to be had, but it's difficult with the sources of data we have right now. If we think it's bad for cardio, which is what I focused on so far, it's even worse for lifting. And our guidelines do recommend 2 sessions per week of lifting, but on a bedrock that is not bedrock whatsoever, on very little data as compared to what we have for cardio. In fact, you look at sources of data. This is a meta-analysis of basically the 6 best studies looking at the association between lifting and long-term health. And this is very counterintuitive. At very low doses, 40, 50 minutes per week, after that we see increases in mortality, right? Lifting is much harder to measure. You don't have wearables, for example, that can tell you how much you're lifting. And this, to me, is a big black hole in a way that we can really improve long-term health to understand this better. So that's the big picture. For the rest of my time, I'll go a little bit into my small picture. As I mentioned, I'm a cardiologist who treats highly active and athletic patients. And they come to me, either they've already had a cardiovascular event or they recognize that their cardiovascular risk profile isn't optimized and they want further advice on that. And when I think about risk factors, I do think about them in 2 different paradigms. I am a classic cardiologist, so I'll use the American Heart Association Essential 8. But I also like the American College of Lifestyle Medicine 6 Pillars that gets into some things we've already mentioned, stress reduction, social connection, that are really important for long-term health as well. My patients come in and they've optimized the physical activity cube here. They're doing more than enough exercise to live their longest. And if they're coming in already having recognized their cardiovascular risk factors are not optimized or already having had an event, it can be with some indignancy because, I'm already doing everything right with physical activity. How is it that my blood pressure is still high, my lipids are still not great, I have prediabetes or something like that? And, it brings home the point that, if you're only focusing on one sphere here, that high physical activity levels benefit all of these things, but do not universally protect all humans from developing some of these cardiovascular risk factors. So you have to get over that initial ego about it. And, flipping the tables a bit, and a lot of my recent work has focused on the question of what is the impact of super high doses of physical activity if your human body is in a milieu of not having all these risk factors controlled, right? And we have so much of what's already been said at this conference plays right into this. Jordan, what ages us? Oxygen, which you burn more of when you exercise. Gravity, maybe that's a little bit more with exercise and time, right? So to unfurl this story, I'll start 15 years ago. I was in training in cardiac CT. I know others in the audience are expert in this, was just coming on board. It's hard to take pictures of a heart. It's always moving, but we were getting better at doing it. And this test was becoming used more often in clinical as well as research settings. And what was first recognized 15 years ago when athletes versus control participants were looked at, specifically males, is that paradoxically and counterintuitively, male athletes had back then just coronary calcium, but now we've recognized also more coronary atherosclerosis. And this, initially was met with skepticism. A lot of my colleagues who are sports cardiologists are male masters endurance athletes, so there's a little bit of bias there. And the question was, how could physical activity possibly be causing something bad, right? But, we've had a decade and a half to gnaw on this. The quality of the studies has gone up over time. And we've even had longitudinal studies showing that if male masters athletes start out with some atherosclerosis, the dose of exercise they then, elect to continue over a period of time is associated with that atherosclerosis blossoming, right? And, I see these patients in clinic all the time, and it gets me thinking about the why. Now, first of all, it doesn't happen in everyone exposed to high doses of exercise. Women seem largely immune, and there's a huge swath of male masters endurance athletes who don't develop this process. It's the ones that start to develop and then it really blossoms over time are the ones we need to worry about. These are some of the things I think about to focus in on something that's come up a lot over this conference. My current work focuses on inflammation, right? That balance Eric mentioned in his talk yesterday between damage, which is inherent to exercise, and recovery. And the question is, when do we get past the tipping point? Exercise obligates oxidative stress and it obligates inflammation. In some humans, that adaptively resolves and we get back to a homeostatic spot. But in others, it may lead to chronic low levels of inflammation that could impact long-term health and could influence some of these masters athlete maladies we see in sports cardiology. And so this is just some of my work. I'm happy to talk more about this at lunch for those who are coming to my table. I have some funding from the NFL Players Association to look at the relationship between oxidative stress and inflammation in young athletes. These are collegiate football players. And, some athletes do fine with exercise. Each bar represents one human and 12 samplings of oxidative stress and inflammation over their playing season. Some of them look optimized, but some of them don't. And in this population, not surprisingly, those who watch the sport, the ones who seem worse off are those bigger linemen who have higher body mass, higher visceral fat, usually worse diet and all that stuff. They are not able, oftentimes, to adaptively resolve their exercise-mediated inflammation. I also work with the Boston Marathon. And it's interesting to see, I would think that exercise would provoke inflammation in everyone who's run 26.2, but that response is even heterogeneous. Some people come off the finish line and in the first couple of days are highly inflamed, and other folks have very little inflammatory response. Suffice to say, my interest, because I treat patients who, they exercise adds life to their days. If it doesn't add days to their life, right, they're going to want to continue to do these high levels of exercise, and my interest is in figuring out how we can move that tipping point, optimizing recovery and nutrition to facilitate high levels of physical activity, even if it's not leading to longevity. As we zoom back out to the bigger picture questions, and I know we're about to start this part, I'd sort of think of it in 3 bins. Like, we have so much data about physical activity and long-term health. From a public health perspective, the most important thing, such high value, is how do we motivate human movement, right? And that's not really my field of research, but it's so important. Social determinants of health play into access to physical activity. How do we help humans move more, right? Bin number 2 is we've got these 2 sources of data that help inform the relationship between physical activity and health: observational, which we can't say cause, and the short-term interventions. And how do we bridge the gap between the 2 of those? Everyone's wired for sound. My patients will come in with a Whoop on one wrist, a Garmin on the other, and an Oura ring on the, we're tracking ourselves more than ever now. And then we have these awesome biomarkers that maybe are not surrogate endpoints that really do tell us something about longevity. Can we connect in the middle somewhere there with our data source to be able to nuance optimal levels of physical activity? And then, not to be a naysayer, but I do wonder whether there's no one right dose for everyone, right? Because as I was showing you, even something simple like inflammation, your response to exercise is going to differ depending on the company it keeps.